Chapter 8 will discuss fluid, electrolytes, and acid-base balance. So we're going to start with fluids, but just some kind of terms and some things that should be familiar to you already. Fluids, ions, non-electrolytes, and electrolytes. There is many different body fluids, things like plasma, different fluids that cushion joints, fluids in the eyes, mucous membranes. So a lot of places where we have body fluids. Ions really just refer to anything with a charge. The other thing to know about body fluids is that we're going to divide them into intracellular spaces and extracellular spaces, and we'll talk about that in a moment. And then there are also electrolytes and non-electrolytes. And non-electrolytes are things like protein or glucose that can be dissolved in fluids. And electrolytes are things like sodium, potassium, and calcium. So there are a lot of different functions of body fluids. They're very important to maintaining homeostasis within the body. So things like regulating body temperature, the transport of nutrients and oxygen, removing waste products, moisturizing tissues, lubricating joints, regulating blood pressure, and supporting digestion are some of the major functions of bodily fluids. So how are they distributed? Remember, we mentioned intracellular versus extracellular compartments, and this is going to be a very important concept for you to really understand, a lot of what we're going to talk about throughout this unit. So intracellular compartments, or the ICF, are all the fluids contained within the billions of cells in the body. This is really the larger of the two compartments. It holds 2/3 of the body water in a healthy adult. The primary electrolyte within the intracellular compartment is potassium. And then there's the extracellular compartment, or the fluid that's outside of the cells, the ECF. And this is the remaining 1/3 of body water. So all the fluid outside the cells, and this includes both the interstitial fluid, the stuff that kind of bathes the cells of the tissues, as well as the fluid inside of the blood vessels. And this is where we have a high concentration of sodium. So you can kind of see that in the picture, right? The red lines, these are blood vessels. And then right outside of them, you can kind of see that interstitium in purple, or that's also outside the cells. So that is what we're talking about with extracellular fluid, or that extracellular space, 1/3 of the fluid. And then inside of the cells themselves is that intracellular compartment where we hold the majority of water. So a little bit more about the composition of the extracellular fluid, also the plasma and the interstitial fluids. So this is the stuff outside of the cell, right? So there are large amounts of sodium and chloride. So you can kind of see that here. This is the plasma, large amounts of sodium, a little bicarb, a lot of chloride that's bound to sodium. And also in that interstitial fluid, kind of the same makeup. The makeup of the plasma and the interstitial fluid is really very similar, both of those extracellular fluids. A little tiny bit of calcium, there's a little magnesium in there, a little bit of potassium, and a little bit of phosphate. And you can see here, this is that intracellular fluid, and it's important to note what kind of cell this was taken from. It's a skeletal muscle. So note just a tiny little bit of sodium, a large amount of potassium. This particular cell also has a large amount of phosphorus. We'll talk about that more, I think, in a moment. And then quite a bit of kind of protein ions and some other things. But the big thing to note here is really that potassium and sodium difference. So again, a little bit more about composition of the ICF, or the intracellular fluid. So again, that's this graph way over on the right. So you'll notice no calcium. And why no calcium? Well, if you remember back to some of the things that can damage cells, high levels of calcium is actually something that can cause significant amount of damage to a cell itself. So we really do not see much calcium at all in that intracellular space. So the diagram also has those really high levels of phosphorus. If you look in the book, it mentions that phosphorus inside of the cells is either a smaller amount or really variable. So thinking about why this particular diagram has such a high level of phosphorus when the book says a little bit differently. Well, again, this is a skeletal muscle. And because phosphorus is largely involved in energy production, it does make sense that a muscle cell would have a large amount of phosphorus for that reason. Again, almost no calcium. The majority of calcium is stored in bone, as is phosphorus, very small amounts of sodium, large amounts of potassium. Okay. So this table came directly from your book, and it shows the different concentrations of extracellular and intracellular electrolytes in an adult. So extracellular is on this side, these two columns, and then intracellular over here. I would perhaps look at, when we look at lab values, what we're going to measure in the body and what will be reported from a lab, it's always this extracellular concentration for all of our electrolytes. And that makes sense because what we draw, right, is serum, which is extracellular fluid. And so this column on the far left is really what you're going to get reported in lab values. But I think the biggest thing that this kind of shows, if you look at the SI units, the millimolar per liter, of all the different electrolytes, either intracellular or extracellular, you can see the significant differences between the concentrations of different electrolytes, either intracellularly or extracellularly. So this might be a good thing to refer to when you are studying where different electrolytes are. The concepts of diffusion and osmosis, these should be quite familiar to you at this point. I'm not going to go over this too much, but if you need a refresher, please look this over, how things move across a concentration gradient and how water moves. This movement of water is very important when we talk about things like sodium, because sodium is the primary regulator and puller of water from one compartment to another. And so that osmosis concept is very, very important. Another new concept for you is something called tonicity. Tonicity is the ability of a solution to cause a cell to either gain or lose water, and it really depends on the concentration of a solute. So within the body, in its normal hemostasis, fluid is not, actively really moving from compartment to compartment. There should be some homeostasis of where that fluid is. But we can, when administering fluids of different tonicities, we can cause fluid to shift from one compartment to another. These shifts also happen when things occur like excessive sodium intake, or these shifts can occur with elevated blood glucose levels, because it changes the tonicity or the concentration of solutes in one of the fluids. It starts to pull water, okay? When we talk about the tonicity of a fluid, solutions are either isotonic, hypotonic, or hypertonic. And again, these are defined by what they would do to the cell if those fluids at those tonicities were introduced, right? So an isotonic solution is a solution that has the same tonicity as typical serum does, as the typical fluid within the body. And so this is something like normal saline has the same tonicity as what we typically find in the body. And so because of that, it wouldn't cause the cell to either shrink or swell. The cell would stay exactly the same. There would be no net movement of fluid across the membrane of the cell. That's illustrated in this middle picture here. A hypotonic solution is a solution that has fewer solutes than what is typically in the body. And because of this, if we give something that is hypotonic into that extracellular space, we start to increase the overall water and decrease the overall level of solutes. And because of this, excuse me, we will pull water um, from an area of higher solute concentration, from an area of lower solute concentration to an area of higher concentration. So all the way on the right is what we see in a hypotonic solution. We have that very dilute extracellular fluid, a lot more solutes now residing within the cell. So we're going to have this overall net movement of water inside the cell. And in a hypotonic solution, that causes those cells to expand or swell. And if they swell too much, they can actually explode, kind of like what you see right here, causing cellular death. And finally, a hypertonic solution. And this is a solution that has a lot more solutes than typical bodily fluids would. So if we introduce a fluid like this, we significantly increase the amount of solutes that are in the extracellular space. And that will have the net impact of moving water out of the cell to dilute that extracellular fluid where we have more solutes. And as that water moves out of the cells into the extracellular space, we get cells that are shrinking. So our little raisin cells kind of right here. So just really thinking through, if I give different tonicities of fluid, what will happen to the cells? And this will become important too when we start talking about what fluids are most appropriate to administer for patients with different conditions, right? If I have a patient who comes in with hyperglycemia and they have all this extra solute in the extracellular space, and it's already starting to pull water out of the cells and dehydrate them, I need to give something that will help to shift those fluids back into the cells. So in that case, I might be better off giving some kind of hypotonic solution to try to dilute out all of that sugar and get some net movement back into that cellular space. So some different mechanisms that protect that extracellular fluid volume. So within the body, we want to maintain a certain amount of fluid volume within that extracellular space, largely within that vascular bed or in that vascular compartment, within those blood vessels, right? So one of the big things that helps to protect that or control the amount of fluid there is alterations in hemodynamic variables. So things that the body can do to adjust fluid in the extracellular compartment is doing things like vasoconstriction, where the body will narrow down or constrict or narrow those blood vessel lumens. And we can also increase the heart rate. That's a common response to sensing low blood volume or low extracellular fluid volume, is for the body to increase the heart rate. And there are also a lot of alterations in sodium-water balance that help to maintain that ECF volume. So things like isotonic contractions or expansions of that ECF volume, or hypotonic dilution or hypertonic concentration of extracellular sodium brought about by changes in extracellular water. So your body will do a lot of things to change the amount of sodium and water in the body to respond to different hemodynamic changes that might signal changes to that extracellular fluid volume. So if fluid goes down, we may hold more sodium to detract more water. If fluid levels go up, we might excrete more sodium to get rid of more water. So there's this kind of constant mechanism of balance to maintain that extracellular volume at sort of its homeostasis or set point. So a little bit about some of the measurements that we often use also to assess fluid balance within our patients, and these might be familiar to you from 2015. So edema is simply the accumulation of fluid in the extracellular space. So if we've pulled excessive amount of fluids out of that intracellular space, or if we have excessive amount of fluids in the vasculature that's starting to accumulate maybe in that interstitial space, we start to see edema in our patients, or swelling. One type of edema is something that we call pitting. You see that here on this pointer. You see that here on the foot, where someone has pressed their finger into that edema and it leaves a pit. We grade this from 1 to 4, depending on how deep and how long that pit remains after we press down into it. There's also non-pitting edema, where someone is obviously swollen and you can press down into that edematous tissue, but it doesn't maintain that kind of pit like this. The other type of edema that I don't see too often is something called brawny edema. This is something that you can see edematous tissue, you can see that it's swollen, but it doesn't compress very easily. This is something we often associate with things like Graves' disease or that pretibial myxedema. It has to do with the type of fluid that is in that space. In the case of Graves' disease, that fluid that enters that space isn't easily compressed. But really the thing I want you to take away from this is pitting versus non-pitting. Those are quite common in fluid excess situations. And edema can form in several different ways. It can be localized edema, where it's just in one specific area. That's often formed if maybe there's obstruction to venous flow, something that's leaving that fluid kind of right in that general area. There's also general edema. This is most commonly caused by an overall big increase in vascular volume, where we just see kind of edema everywhere. And then the other type is dependent edema, and this is largely caused by an increase in capillary pressure due to gravity. So as a limb like your foot or your ankle is dependent, meaning down towards the ground, the gravity starts to pull a lot of fluid kind of out of that capillary bed and into that interstitial space, which causes this edema in dependent edema. So capillary filtration pressure is pressure that pushes water out of the capillary into that interstitial space. Other things that can do that, that push of water into the interstitium, are things like an increase in arterial or venous pressure that will increase the capillary pressure and push fluid out. So if someone has a lot of pressure in the venous system, like maybe in congestive heart failure where they have a lot of backup, or a big rise in arterial pressure, like with hypertension. There's also something called capillary colloidal osmotic pressure, and that's a pressure that pulls fluid back into the capillary beds. That is largely created by the proteins that are circulating within the vasculature. These proteins are generally too large to pass through that interstitial, into the interstitial space. So they contribute to kind of holding that fluid into that vascular space. And there's also something called tissue colloidal osmotic pressure, and that is the small amount of plasma proteins that escape into that interstitial space from the capillary that pull water out into the tissue spaces. This is explained very well in your textbook with a lot of very nice kind of diagrams. So do familiarize yourself with kind of all of the different pressures that happen within the capillaries that also contribute to net movement of fluid in and out of those capillary. So when we're assessing edema, we can do several different things, and I really want to point out the importance of daily weights. You will definitely get questions throughout your nursing career and also on NCLEX about the best ways to measure fluid volume balance, and it is almost always measuring weight. Weight is an extremely good indicator of increases and decreases in fluid volume. Other things are like your own visual assessment, your own inspection of your patient looking for overt signs of edema. There's also measurement of affected parts. Sometimes people talk about maybe measuring, the girth of the ankle or the fingers to kind of check for edema. And also that application of that finger pressure, especially to check for things like pitting edema. With daily weights, we measure people at the same time every day under the same conditions. So using the same scale, wearing the same clothes or no clothes, because this provides a really useful index of water gain. A liter of water weight is equal to 1 kilogram of weight gain. So if someone gains 2.2 pounds, theoretically they could have gained a liter of water if they've done that quickly overnight. So if someone gains several pounds overnight and they have a high risk of fluid overload, that would be someone we would want to contact their healthcare provider to report that significant fluid increase. So this is a little bit more about how edema forms specific to some of those capillary pressures that we mentioned. So you can see here in the diagram, this is a blood vessel, this is a capillary. In the capillaries, you have one end that is from the arterial system and one end that is from the venous system. And so the capillary beds are where these two systems with oxygenated and deoxygenated blood meet, right? And down here you have the lymph channels. And remember that the lymph channels are collecting any fluid or waste or anything that has kind of made its way out into that interstitial space to kind of prevent any fluid and things from building up within the interstitium as well. So lymph is very important to preventing any edematous buildup of interstitial space. So that's why it's indicated here in the picture. So how does edema form? Well, if we get an increased capillary filtration pressure, so you see that capillary filtration pressure here, that's a pressure that pushes fluid out of the capillary bed. So if that pressure were to increase, we would get a net movement of fluid outside of the capillary. So again, that's things like maybe an increase in arterial or venous pressure would increase the overall pressure in the capillary, pushing fluid out. We could also get edema from a decrease in capillary colloidal osmotic pressure. You see that here, that colloidal osmotic pressure. That's the pressure, again, that pulls fluid back into the capillary bed, and that's largely determined by things like circulating proteins in the vasculature that don't easily move into the interstitium. But if we get someone maybe with liver disease or with malnutrition who maybe has really low levels of proteins within the capillaries, they may develop more edema because the pressure there would lower, and that would allow fluid to leak out into the interstitium. Other things that might change that overall balance is that increased capillary permeability. If the capillary bed becomes more permeable, things like those proteins that normally remain in the capillary bed would start to leak into the interstitium, and they could pull that fluid with them. Remember, that's what happened with things like inflammation, right? Other things, if we have an increase in our tissue hydrostatic pressure, so if the pressure within the tissues starts to increase, we could get a net movement of fluid out of the capillaries. This would be something that would reduce edema. Also, if we get an increase in interstitial fluid pressure, so if we get maybe a lot of leaking of proteins and things again out into this interstitial space, that might again happen with something like capillary permeability, it's going to pull water with it. And the final thing that can often cause edema is obstruction of lymph flow. If these lymph channels become obstructed and we don't have that good flow of fluid out of that interstitial space, it can start to build up here and form edema. So this came directly from your book. It's something for you to review, but just some of the typical causes of edema. This is from page 141 of your patho text that you can kind of read over, but it breaks it down based on the different capillary causes of edema and the different disease states and things that can lead to those happening. Okay, so do review this. Other things that affect body water balance. One abbreviation that we often use is TBW, that stands for total body water. And largely changes in sodium cause changes in water volume. So when we talk about sodium, it's always closely linked to water volume. The significance of sodium levels is usually most closely tied to its significance regarding total body weight. So when we talk about hypo and hypernatremia, a lot of the things we're also going to talk about is the effect of either increase or decreases in sodium and how that affects the movement of water. Total body weight really varies quite a bit by sex and by weight. And the reason for this is because water is the water composition of fat tissue or adipose tissue is extremely low. It's about, I think, 10% of adipose tissue is made up of water. But within muscle tissue, it's more like 70 to 75% of that tissue is made up of water. So someone with higher levels of muscle mass compared to adipose tissue will have more total body weight that is made up of water. So like young men have a much larger total body water composition than maybe a postmenopausal older woman who has higher stores of adipose tissue. Infants also have a high percentage of total body water. Theirs is much higher even than adults. I think it's closer to maybe like 75 to 80%. And this is why we often, infants can often become much more like quickly dehydrated. We worry about their water balance quite a bit more because of that high level of total body water. So different water gains and losses, like how do we bring water in and how do we lose water from the body? We have two different types of losses. We have those that are measurable versus those that we call insensible. So measurable fluid volume losses is typically what we would see in urine. If you're working in a hospital, you probably did this in lab where you measured the amount of urine volume output and you called that, your output, right? That's measurable. But insensible losses are things that we can't measure. So this is the loss of fluid through things like the skin, through the lungs. We also lose water through the GI tract, like in the feces, right? So there are different conditions that can make insensible losses increase. So things like, respiratory infection that causes fever. You would breathe more quickly and lose more fluid out of the lungs, and you might sweat and lose more fluid out of the skin. So when you're taking care of patients who have diseases that are disrupting their homeostasis, you really have to consider water gain and losses. Often when we're looking at I&O in those patients, we don't want a balanced I&O. What we want is a higher intake than output because we need to make up for those insensible losses that we can't measure, right? And so those kind of things, if we're thinking about what would increase insensible losses, those really will influence how we would interpret fluid balance and fluid needs. Again, if someone has what we would consider conditions that would increase those insensible losses, we might be more aggressive in increasing our overall intake versus our output. Okay. So again, with sodium balance, some really key points here. Again, sodium is the most abundant cation in the body. The resting cell membranes, so the cellular membranes within the body, are relatively impermeable to sodium. So sodium is not readily moving across that cell membrane and changing its position. It's not going to be moving typically from areas of higher concentration to low. And this is a good thing because we do want that sodium level to be maintained at higher amounts in that extracellular fluid because that really is helping us maintain that extracellular fluid balance, right? Its main function is really to regulate ECF volume. So again, if it was passing easily into the cell, we wouldn't be able to maintain that volume within the vasculature, which would be catastrophic for our patient, okay? It really helps to regulate that distribution of fluid between the ICF and the ECF. Sodium accounts for most of that osmotic activity in the ECF. So what we think about when we think about how water stays or is pulled into that extracellular fluid, that's because of sodium. It also contributes to the regulation of acid-base balance, which we'll talk about because it really makes up sodium bicarbonate, which is our largest kind of base within the vasculature that helps to buffer any acids that are produced in the body. And it also contributes to the function of any excitable tissues. Remember, its function within things like the sodium and potassium pump to maintain that kind of concentration gradient. And you remember that there are sodium channels that open to allow sodium to rush in to change that gradient from negative to positive. But then that sodium has to be sent back out into the extracellular fluid so that we can maintain that high level of sodium outside and maintain that ECF. And I think you all remember what happens if we can't maintain that with that pump to send the sodium back out, that we get swollen and dead cells. So hypo and hypernatremia, that's brought about by things like disproportionate losses or gains in sodium or water, exert its effects on the ICF compartment, causing water to move in or out of the body fluids. So many of the manifestations or changes in sodium concentration really reflect changes in the intracellular volume of cells, particularly those in the nervous system. So if we have someone with hypernatremia and there's a significant increase in the amount of sodium outside of the cell, we're going to see a significant movement of water out of the cell as well, and those cells can shrink and dehydrate. And vice versa, if we see a significant drop in the sodium in the extracellular fluid, like we see with hyponatremia, we're going to see an increase of net movement into the cell, where we have a larger concentration of solutes, and we're going to get cellular swelling and potentially death. Okay. So a little bit more about sodium gains and losses. In the GI tract and out via the kidneys are the ways that we often lose and gain sodium. So we eat foods with sodium in them, so they come into the GI tract, and then typically that sodium is lost out the kidneys. Okay. We also lose a small amount of sodium out of the GI tract and some out of the skin through sweat, but the majority in through the GI tract, out through the kidneys. So the kidney is really the big driver here of sodium gains and losses. And the kidney is very efficient at the regulation of sodium. It reabsorbs more sodium when needed, like when the extracellular fluid drops, and it filters it out when we don't need it, like when the extracellular fluid levels increase. So very efficient filtration that we'll talk a little bit more about. We can sometimes see increases in the loss of sodium via the GI tract, especially in states like vomiting and diarrhea or GI suctioning that we sometimes do within healthcare institutions for various reasons. And you can also see an increase in the sodium that's lost via the skin, especially with someone who's aggressively maybe exercising, especially in hot weather. We see more sodium lost through sweat. So a little bit more about mechanisms of regulation of water and sodium. So the major regulator of the amount of sodium and water within the body is something that we call the effective circulating volume, the amount of blood circulating throughout the vasculature in the body. If your body senses low volume or low effective circulating volume, it will act to increase renal sodium and water retention. If we sense high volume or high effective circulating volume, then your kidney will decrease the amount of sodium and water that it retains, and more will be lost through the urine. How does your body know what the volume is? Well, high and low volume are measured by sensors within the body called baroreceptors. And what baroreceptors essentially are sensing is stretch. So the baroreceptors are located right within the vasculature. So they're in areas of the circulation itself. So we have some baroreceptors on what we call the low pressure side of circulation, so in the atria or in the pulmonary blood vessels. And if those areas of circulation start to stretch or start to become full, that signals those baroreceptors to say, hey, we have a high volume here. And we also have baroreceptors located on the high pressure arterial side, and those can also respond to increases in volume in the arterial system. Again, the arterial system starts to stretch, and it says to the baroreceptors, hey, we've got a high amount of volume. And vice versa, they can also sense when there's very low levels of stretch, and signal, low volume. So these baroreceptors are really those sensors within the vasculature that are doing the signaling to say that we either have high or low volume in that effective circulating volume. So one of the major regulators of sodium and water balance is this RAS system. So we already talked about baroreceptors, but what happens after baroreceptors are activated either by low or high circulating volumes? So baroreceptors then go forward and kind of modulate the sympathetic nervous system and also something called ADH secretion that I think we'll talk about a little bit more. But the sympathetic nervous system can directly adjust things like the glomerular filtration rate within the kidneys, and also things like tubular reabsorption of sodium and right in the kidneys themselves. But the other major thing the sympathetic nervous system can do is it can stimulate the release of renin. And renin is an enzyme that is released directly into the bloodstream when the kidneys detect a drop or an overall drop in blood pressure. And renin is what activates the renin-angiotensin-aldosterone system that works to overall create an increase in blood pressure when circulating volume drops. So again, renin is an enzyme, and when volume drops, the kidneys release renin into the bloodstream where it interacts with a circulating plasma protein called angiotensin to make something called angiotensin 1. Then another enzyme called angiotensin converting enzyme converts that angiotensin 1 to angiotensin 2. And angiotensin 2, which you see here, can act directly on the vasculature to cause this overall vasoconstriction, so tightening down or clamping down of the blood vessels. And it can also signal the kidney to increase the amount of sodium that is being reabsorbed, which also pulls water with it. So overall, again, just that action of angiotensin 2 causes vasoconstriction, retention of water and sodium, which leads to this blood pressure increase. Angiotensin 2 also can activate aldosterone within the adrenal glands, and that aldosterone will further act to hold on to more water and sodium, but also to excrete more potassium, because as you recall, that's what aldosterone does. But these overall actions, both the direct action of angiotensin 2 on the kidneys and blood vessels, as well as its action to activate aldosterone, causes this significant increase in blood pressure, again, to counteract that drop that was sensed by the kidneys. And the other system that we mentioned was ADH. So we're going to talk about both thirst and ADH. So these are things that either increase or decrease fluid balance as well. So thirst, or that that feeling that people get when they need more fluid volume, is really the primary regulator of water intake. When you get thirsty, you drink water, and that is really what's regulating kind of your intake. And ADH is a primary regulator of water output. And both of these systems, both ADH and thirst, will respond to changes in extracellular fluid osmolality. So really, again, the overall concentration of solutes in the extracellular space. So if that solute level increases and then we have a higher osmolality, you get thirsty and you drink water. If we have high osmolality in the body, we might hold in more water to try to dilute that. So the effect of isotonic fluid excess and deficit, or hyponatremia and hypernatremia, on the movement of water between the extracellular and intracellular fluid compartments is largely controlled by thirst and ADH. ADH is the antidiuretic hormone, and it is kind of what it sounds like. When ADH is released, antidiuresis means that it signals the kidney to hold on to more water. So again, ADH would be released if we have an increase in osmolality to try to bring that ECF osmolality back into normal levels. The hypothalamus itself, which you see right here, contains what we call osmoreceptors. And those osmoreceptors are what are responding to those changes in osmolality, and they will signal the pituitary gland to secrete ADH. And they'll also signal portions of the hypothalamus to signal that thirst output, okay? Thirst is controlled by the thirst center within the hypothalamus, And there are two stimuli for true thirst based on water needs. One is cellular dehydration. That's caused when we have an increase in ECF osmolality that pulls fluid from the cells. And they also can respond to a decrease in blood volume, which may or may not be even associated with decreased serum osmolality, but will also stimulate, again, that thirst center. So hypothalamic thirst center signals thirst. We drink water. We increased our extracellular fluid volume and reduce the osmolality to turn off that thirst center. But if serum osmolality goes up, we will again signal the hypothalamus to signal thirst. Also would be secretion of ADH. So osmolality goes up. We secrete ADH. It's antidiuresis, so we get reabsorption of water by the kidney, and we get an increase in water volume. Okay. So there are some things that can affect our ability to properly sense or have that kind of sensation of thirst, things that kind of interrupt that thirst drive, which again is kind of our primary driver of fluid intake. So different disorders of thirst. We might have something called hypodipsia, where we have a patient with a decreased thirst sensation. So things like hypothalamic lesions, so damage to the hypothalamus itself, which might directly damage that thirst center. So things like head trauma, meningiomas, subarachnoid hemorrhages might cause this. And also we see hypodipsia often in older adults, especially those over the age of 80, and especially those older adults over 80 who maybe have suffered things like a stroke or have some kind of sensory, cognitive, or motor disturbance. They often have hypodipsia, so they're at high risk of water loss. Polydipsia is excessive thirst. We talked about this already with things like diabetes, right? And polydipsia can really fall into kind of three categories. One is symptomatic or true thirst. There's also inappropriate or false thirst. And there's finally something called compulsive water drinking or psychogenic polydipsia. Among the most common causes of symptomatic thirst or true thirst are water losses associated with things like diarrhea, vomiting, diabetes, and diabetes insipidus, which we'll talk about. Inappropriate or excessive or false thirst is thirst that may persist beyond things like adequate hydration. It's a common complaint in people with maybe congestive heart failure or diabetes or CKD or chronic kidney disease. Thirst is also a common complaint in people maybe with dry mouth that's caused by like decreased salivary function, often associated with treatment, like maybe with drugs like anticholinergics, antihistamines, and atropine, which cause kind of that overall decrease in salivary flow. And the final one, that compulsive water drinking or psychogenic polydipsia, involves really this compulsive water drinking. And it's usually seen in people with psychiatric disorders, most commonly in schizophrenia. And people with this disorder will just drink really large amounts of water and excrete huge amounts of urine. The cause of excessive water drinking in these people is really uncertain. We're not sure why they do this, but it's often compounded, especially in those with psychotic disorders, by the medications they take that increase ADH levels and further interfere with water excretion by the kidney. But excessive water ingestion coupled with impaired water excretion, or if we're rapidly ingesting water at a rate that exceeds our kidney's ability to excrete it, can lead people with psychogenic polydipsia to something called water intoxication. And they get really severe symptoms of hyponatremia, which we'll talk about shortly, but things like potentially they could get seizures and loss of consciousness. Usually the neuro kind of symptoms are really the most significant in this polydipsia state. These folks are so compulsive with water drinking, they have to be often kept away from any water source. Like even, they'll drink out of toilets. Anywhere with water, they will seek it out. And there are also people who develop disorders of ADH expression. So one of those disorders is something called diabetes insipidus. And in diabetes insipidus, or DI, there is an overall deficiency of a decreased response to ADH. So if we're not secreting enough antidiuretic hormone, or the body is not responding to antidiuretic hormone, and so because of this overall deficiency, we're not holding any water in. There's not that antidiuresis effect. So people with DI, and this is why we call it DI, because remember in diabetes, these patients had a whole bunch of polyuria. Patients with DI also have a whole bunch of polyuria, a whole bunch of urinary output because of the absence of ADH. So patients with DI are unable to concentrate urine during periods of water restriction, and they excrete really large volumes of urine. The other disorder of ADH is SIADH. This is a failure of that negative feedback system that regulates the release and inhibition of ADH. So in people with SIADH, so people with this syndrome, ADH secretion continues even when serum osmolality is decreased. So normally when serum osmolality goes down, we would turn off ADH. But in these patients, that ADH excretion just kind of continues and continues with no negative feedback mechanism. So this causes a really significant increase in water retention because ADH continues to kind of, be poured out. It is opposing diuresis, and so SIADH patients retain a significant amount of water, and all that water retention starts to dilute that extracellular fluid and causes severe hyponatremia in those patients. Some potential causes of SIADH might be things like drugs, other things like surgery, significant pain, stress, or temperature changes. Different hypothalamic tumors can cause SIADH, mechanical ventilation, damage to the CNS. And again, the manifestations of SIADH are really similar to those of dilutional hyponatremia, which we'll talk about. So we get high urine osmolality, so a lot of solutes in the urine. And then the serum osmolality drops significantly. Urine output decreases despite adequate or increased fluid intake. So we put fluid in, it never comes back out. Hematocrit and plasma sodium and BUN levels all decrease because they're being diluted by all this fluid that's being retained in the ECF. So when we diagnose SIADH, it has some cardinal features. There's 5 of them that we need to diagnose SIADH. One is hypotonic hyponatremia. One is something called natriuresis. Another is the urine osmolality that is in excess of plasma osmolality, so very concentrated urine and very dilute plasma. And also there's an absence of edema and volume depletion, and we have normal renal, thyroid, and adrenal function. So we have to rule out those things as potential causes of that overall water retention. A little bit more too about diabetes insipidus. There are 2 kind of major types of DI. One is central or neurogenic DI, and this occurs because of a defect in the synthesis or release of ADH right from the hypothalamus. And there's also nephrogenic DI, which occurs because the kidneys aren't responding to DI or to ADH. Remember, DI can either be a problem of excretion of ADH or a problem of sensing, and so those are kind of the 2 different causes. And DI overall causes this hypertonic dehydration and increased serum osmolality. So we're dumping a whole bunch of fluid out. We're retaining all of the solutes. So we get hypertonic dehydration where we're pulling fluid out of the cells themselves. And the serum gets a really high osmolality with all that serum concentration of solutes. Causes of DI, certain drugs will do this, things like lithium, head injuries or surgeries that happen near the hypothalamo-fascial tract. Often these causes are temporary and they'll resolve themselves when things like trauma and inflammation go down. We can differentiate the different causes of DI by giving ADH. If we give someone ADH, we give it subcutaneously, and they still don't respond, then it's probably a nephrogenic diabetes insipidus, meaning that the body just can't sense ADH. If we give ADH and the patient does respond, then it is most likely a neurogenic cause, and the sensors are fine. We're just not overall making any ADH. Okay. All right, on to a little bit more about disorders of sodium and water balance. We can get what we call isotonic contraction or expansion of the ECF. So isotonic fluid volume deficit or isotonic fluid volume excess. And this means that there's not an overall change to the tonicity of any of the bodily fluids. We just get either an increase or decrease of fluid overall. And we can also get hypotonic dilution, and we usually call this hyponatremia, or hypertonic concentration or hypernatremia of that extracellular sodium. Okay, and these can be caused by changes in water, extracellular water. So if we introduce a lot of extracellular water, we can cause a hypotonic dilution. If we pull a lot of water out, leaving sodium behind, we can cause a hypertonic state or hypernatremia. And so these changes in water balance produce a change in osmolality of the ECF and an overall movement of water between the ICF and ECF compartments. So in these hypo and hypertonic solutions, we see water moving between the ICF and ECF. In isotonic changes, we don't typically see those net movements of water in and out. We see an overall expansion of ECF or a decrease in ECF. So again, within the different types of water balance disorders or water balance deficits, we have both isotonic and hypertonic types. So we're going to start with the isotonic type, so isotonic fluid volume deficit. And so this is where we have a proportionate or kind of equal loss of both sodium and water. So if we're losing them in equal proportions, what's left behind is still that kind of isotonic type fluid. No big changes in tonicity in this case. So we often call this hypovolemia, so just low overall volume. So it can be caused by body fluid loss or an overall decrease in intake. So inadequate fluid intake might be caused by things like oral trauma or significant swallowing impairments. It may happen to someone maybe with impaired mobility who can't obtain sufficient fluids. It might happen to somebody with some of those disorders of thirst that we talk about who don't have that kind of drive to take in fluid, or it might be somebody who maybe has an overall maybe decrease in their level of consciousness. Other things that can cause this are things like excessive GI loss, maybe through vomiting, diarrhea, or suction. It can happen through things like excessive renal losses, like during significant diuretic therapies, or for patients who are hyperglycemic, who are having fluid pulled out of the system by blood glucose levels. And it can also happen in patients with adrenal insufficiency who don't make sufficient amounts of aldosterone to maintain that fluid and water balance. It can also happen through excessive skin loss. So patients maybe who are febrile or who are in excessively hot environments, increasing their amount of sweat. And it can also happen in patients with significant amounts of burns or skin wounds where they lose a lot of fluid through, through the skin. And the final thing is something called third space loss. And so in third spacing, you are not necessarily losing fluid from the body. What you're doing is sequestering or moving that fluid into a space where the fluid is still in the body, but it's no longer part of that circulating volume. So these are fluids like that. Maybe there's a condition called ascites where people build up fluid within their peritoneal or abdominal cavity. And so that fluid is still in the body, but it's no longer in the vasculature. So technically these people are hypovolemic because their volume within the vasculature is down, but their overall total body water and total body weight will remain the same. It's just, again, sequestered volume. So this happens maybe in patients who have an intestinal obstruction. They start to hold a lot of fluid, or people with a lot of edema where they have all of that kind of fluid that's filtered out into that interstitial space, or patients again with that condition called ascites where they build fluid up within the peritoneal cavity. So what kind of assessment findings do we see in a patient who has fluid volume deficit or hypovolemia? So first, we would really do a good history and physical to try to look for any potential etiologies that we kind of just mentioned, some of those common causes of fluid volume deficit. And then other things we would look at are maybe heart rate and blood pressure. This patient would typically be tachycardic or have an elevated heart rate and be have a low blood pressure, and they also develop commonly things like postural hypotension. They have a lot of difficulty, again, maintaining their blood pressure. Their pulse would be fast, but also kind of weak and thready. Their capillary refill time would be slowed. They might be thirsty, depending on the cause. Their weight would drop. Their urine output would drop. Other things that we might see, and some of these too, we especially see in maybe infants or babies with fluid volume deficit, things like sunken eyes and sunken fontanelles, and things like poor skin turgor. Other things that you see in the little cartoon here, things like restlessness, lethargy, and weakness and confusion may also develop as fluid volume deficit especially starts to drop. There's also some lab findings in here that you may want to look at, things like urine-specific gravity might go up. BUN might increase, hemoglobin to hematocrit ratios, and RBCs. And this has to do again with loss of fluid within the system. So some of these serum levels may increase as we lose overall fluid in the body. So treatment for isotonic fluid deficit, I'm just going to mention it before we move on to excess, would really be to replace that fluid, right? You would find the underlying cause of why the person had lost volume, and then you would replace it. So now we'll move on to isotonic fluid volume excess. So this is isotonic expansion of the extracellular fluid compartment with increases in both interstitial and vascular volumes. So just kind of overall fluid volume increase both in that vascular space as well as in the interstitium or kind of around the cells. We can see an increase in total body sodium, but it's also accompanied by a proportionate increase in body water. So again, we maintain that kind of isotonic ratio. So some typical causes here, one big one in the most common cause of fluid volume excess is renal function. These patients really lose their ability to kind of concentrate and excrete urine, and so they are particularly vulnerable to fluid volume excess. Other patients, heart failure patients, also very vulnerable to fluid volume excess. They tend to have lower circulating pressures, and so they have less perfusion to things like the kidneys, and so their urine output and their ability to excrete water does reduce. In liver failure patients, we also see things like fluid volume excess. Liver failure patients, they tend to have difficulties with things like, for instance, they have a reduction in overall like circulating proteins. We produce and package a lot of the proteins that you see in the serum within the liver. So as the liver starts to fail, we see things like a drop in albumin, a drop in overall protein levels. And if you remember back to some of the capillary pressures that we talked about and how we keep fluid in that intravascular space, a lot of it is driven by protein. And so if we have a patient with low protein, we also have a patient with low kind of that osmotic pressure that holds fluid in, and that fluid starts to leak out into the interstitium. And so because fluid volume excess is both in the interstitial and in the vascular volume, in liver failure patients, we get a lot of that kind of third spacing or that increase in fluid because of that overall loss of protein. And finally, corticosteroid excess. And the reason here is really largely related to that increase in circulating aldosterone that ends up holding in fluid and salt. So again, renal patients can't eliminate sodium in water. Heart failure patients have reduced circulating volume with less overall flow to the kidneys. Liver failure patients have less circulating volume, less protein volume. They also don't metabolize aldosterone well. And again, corticosteroid excess increases sodium reabsorption by the kidneys, leading to increased fluid. So how do we assess fluid volume excess? Well, these are some of the things we would see. So a gain in weight and edema. We'd see a dilutional effect on the lab. So things like hematocrit might go down, hemoglobin hematocrit would drop, BUN would drop. Again, more fluid volume dilutes a lot of those other components that we see in the serum. Things like distended neck veins, bounding pulses, and shortness of breath if that edema starts to affect the pulmonary system. Other things, some neurological changes that you can review here. And then sometimes we also see things like anorexia and nausea as we get changes to gastrointestinal peristaltic activity. So treatment for fluid volume excess, one of the big things that we do is maybe restrict sodium, especially if it's maybe a renal patient or a cardiovascular patient who tends to hold fluid a lot. We wouldn't want them to take in additional sodium. And then diuretic therapy is really one of our mainstays of treatment for fluid volume excess. Hyponatremia. So this is a relative drop in the amount of sodium in the extracellular space. So hyponatremia is relatively common. Older adults are far more vulnerable to experiencing hyponatremia because there's a lot of different age-related events that make them that way. Things like decreased renal function, limitations in sodium conservation, also things that might impair thirst or might impair uh, things like mobility could be involved here. Um, they just have a lower kind of overall ability to withstand different like environmental, drug-related, or disease-associated stressors. So that's what makes older adults kind of more vulnerable. So in hyponatremia is really, you know, too little sodium at the end of the day, but there's different kind of types of hyponatremia. So, where does all this salt loss come from? We can have what we call hypertonic hyponatremia. And in this case, what ends up happening is we get this significant shift of ICF to ECF water. So in this patient, there's something that's causing an overall significant increase in tonicity in the extracellular fluid or in the blood volume. So again, maybe something like elevated blood sugar levels. And so we end up getting this net pull of water outside or from the cells into the vasculature. And with all this shift of water into the ECF, it dilutes the vascular compartment. And so it's still hypertonic in nature. There's some kind of solute there that is increasing the tonicity, but that solute is not sodium. And so water gets pulled nonetheless. The sodium levels remain the same, but now the water level has increased so much that it's diluted down and has caused hyponatremia. So that's one cause. Other causes are these dilutional types. So dilutional hyponatremia, and these are far more common, and they're usually caused by things that cause like water retention. But we can also get hypovolemic hyponatremia, where we have someone who loses just a whole bunch of fluid um, um, and salt with it that causes hyponatremia. We can get euvolemic loss, where their volume kind of stays the same, but we lose too much sodium. And then we could get hypervolemic, again, where maybe we have too much water introduced that dilutes down the sodium. So we're going to talk about those causes a little bit more here. So here are some more specifics about hypo-U and hypervolemic hyponatremia. So hypovolemic is water that is lost without taking sodium with it. So we're just losing a lot of water, leaving the sodium behind. So this happens in conditions maybe where someone is doing a lot of sweating, where they're losing both sodium and water, but then they're replacing only the water aspect. And so then they get hyponatremia. GI loss can also happen where we have disproportionate ingestion of parenteral water. So if someone is losing a lot of sodium and water through the GI tract, maybe through diarrhea or vomiting, but they're just replacing with straight water and no sodium, they can become hyponatremic. We also see this in infants. One of the things we tell new parents is that they should never dilute formula. It should only be mixed at the appropriate amount. And we also don't give tap water to infants. The fluid that they ingest should be either breast milk or formula, because you can cause hypovolemic hyponatremia in these patients really easily by giving diluted formulas. And another common cause of hyponatremia is adrenal insufficiency, where if we don't have aldosterone, we lose a lot of sodium and water. A euvolemic cause, where we have retention of water with dilution of sodium. This is truly the most common cause of hyponatremia. And one big contributor here is SIADH, syndrome of inappropriate ADH. So again, these patients are, if we don't have antidiuretic hormone, we retain a lot of, if we're not responding to that in the right way, we have a lot of retention of water that dilutes that sodium. This can often be caused by this post-surgical increase in ADH as well. So again, remembering back to SIADH in these patients, that normal negative feedback mechanism that would typically shut off the production of ADH when we have like enough, normal circulating volumes or normal osmolalities, that does not occur. Um, and so antidiuretic hormone continues to be produced, and antidiuretic hormone causes that retention of water that dilutes down all the sodium in the body. So again, SAADH is a common cause of hyponatremia. And then hypervolemic. These are usually our edema-associated disorders. So things like heart failure, advanced liver disease, or renal disease that might cause kind of a lot of that like third spacing or movement of fluid out of the vascular compartment. Um, that kind of pulls sodium, or excuse me, pulls kind of water into that space. So we get a lot of volume, but not a lot of sodium. So hyponatremia's clinical manifestations. So often the manifestations depend on how rapid the onset of hyponatremia is and the severity. We can get pretty far out of normal sodium ranges before patients start to show signs and symptoms of hyponatremia. But things that we do, you can remember them by this kind of little acronym of SALT loss. So stupor and coma, so they can have neurological changes, loss of appetite, they become lethargic, and their deep tendon reflexes tend to be depressed. They also get kind of limp muscles, orthostatic hypotension. They can develop seizures and stomach cramping. So again, that's kind of a good way to sort of remember some of the common hyponatremic clinical manifestations. And treatment of this really depends on the cause. So we may need to limit water intake. If it's a dilutional kind of thing where we've got too much water intake without enough salt, we need to stop the water intake. We might need to administer normal saline, which would increase sodium. Or if we have an extremely severe hyponatremia, we might need to give like a hypertonic saline solution, maybe with a diuretic to increase salt and reduce water. Hypertonic saline solutions, we actually have something called a 3% saline solution. That's what we talk about when we mean hypertonic. So then we'll talk about hypernatremia. So this is when sodium levels go above 145 milliequivalents per liter in the body. The normal sodium levels are 135 to 145. And so when somebody's hypernatremic, it starts to induce this water movement where we pull water out of the cells. So often we see what we call cellular dehydration in these patients. So this is usually pure water or water loss with low concentrations of sodium in the urine. So maybe someone who is maybe has some kidney issue where they're not excreting salt, they're just excreting water. And so what's left behind is this hypernatremic state, or maybe we lost the GI tract where we're largely losing water, or maybe through the skin, or often maybe through the respiratory tract. So if someone maybe has a respiratory disorder where they're breathing really fast, like maybe a pneumonia, and they have a really large amount of fluid loss through the respiratory tract, it leaves behind a lot of sodium. Other things that can cause this is maybe a defect in thirst or an inability to obtain water. And we can also cause it by a rapid infusion of sodium. So the acronym MODEL might help you remember some of the common causes of hypernatremia. Others are things like medications or meals. So if we're giving a fluid or giving a medication that has a really high salt content, or if somebody is eating a really high salt content. We also have something called an osmotic diuretic. I'm not sure if you guys learned about this in pharmacology, but for patients who maybe have intracellular fluid expansion, so or cellular edema that we want to correct. So we use these sometimes maybe in a patient with cerebral edema to try to pull fluid out of the cells. We give these really high salt level diuretics to do that, but that can also give people hypernatremia. Diabetes insipidus is another cause of hypernatremia. So remember, in diabetes insipidus, these patients are losing large volumes of fluid, and so they often have high levels of sodium that are left behind. So hypernatremia and DI is a common combination. Other patients might lose excessive amounts of water, again, through whatever loss it might be, whether it's skin, whether it's GI tract, whether it's respiratory tract, or in patients with low H2O intake. So again, patients who maybe don't have a thirst mechanism or who can't get to water. So hypernatremia, again, the water is being pulled out of the cells. So that's what leads to many of the signs and symptoms that we see with hypernatremia. And so I have here that BP is elevated if the cause is overall salt intake. So on my little acronym over here, you see that one of the issues that it mentions is here of elevated blood pressure. But you'll also see in your reading that they also associate low BP, weak and thready pulses, low volumes with hypernatremia. And that is also true if the hypernatremia is being caused by large volume fluid loss. So what we see with some of those vital signs like blood pressure and pulse can be related to the cause of hypernatremia. Again, if it's caused by an excessive amount of salt intake, you might see elevated BP. If it's caused by an excessive amount of fluid loss, you might see a low blood pressure. But again, this acronym might help you kind of remember some of the common signs and symptoms that we see with hypernatremia. So fried and salted. So sometimes hypernatremic patients get this kind of low-grade fever. They tend to be kind of warm and flushed and kind of uncomfortable feeling that way. They can also develop restlessness and agitation. Increased fluid retention might start to happen because of the increased salt levels. They may develop edema, peripheral end pitting types, and they're going to have a dry mouth. They're going to feel thirsty. They may be flushed, have altered LOCs. Their urine output may start to drop because they're going to start to retain fluid. They might be thirsty, their blood pressure can go up, and they may have decreased energy levels. So again, these are some of the common things associated with hypernatremia. How we treat it? Well, we would treat the cause of hypernatremia and we would try to replace fluid to reduce the overall levels of salt. Fluid replacement, if we can, is preferably done orally, but if we can't do it that way, we can replace fluid intravenously. But especially for patients who maybe have severe cases of hypernatremia or who have kind of chronic hypernatremia, you do want to replace that fluid pretty carefully. So relatively slowly. You don't want to just give them a whole bunch of fluid all at once because that can cause like really significant and big shifts of fluid. And especially these big shifts of water movement like back into brain cells. So you can actually give people cerebral edema if you try to treat hypernatremia with fluids too aggressively. So we do need to do that with a bit of care. So this would be a good time to maybe take a break because we're going to move from fluid balance to some discussion surrounding electrolyte imbalance. So give you an opportunity to kind of take a little break here. But now we're going to move on to potassium balance. So potassium is one of our main electrolytes. It is our primary intracellular electrolyte. So its intracellular concentration is 140 to 150 milliequivalents, but its extracellular concentration is 3.5 to 5. And I have that highlighted because when you look at lab values and when someone asks you what is the normal value of potassium, you are going to cite and talk about the extracellular concentration because that is serum and that's what we typically test. So for your purposes, concentration is 3.5 to 5. Okay. The body stores of potassium are really related to body size and muscle mass, but I will tell you that the body stores very little potassium. The majority of the potassium that we need for day-to-day processes needs to come in from dietary sources. So because of that, it's pretty easy to become low in potassium, especially if you have someone who has a poor diet and who doesn't have a lot of dietary intake of potassium. Again, we don't really have a mechanism to store potassium significantly. So it will be important for you guys to know different dietary sources of potassium. You'll learn about many of those in your different med-surg classes, but you will definitely get questions on your NCLEX about good sources of potassium in the dietary realm because we don't store it. And you need a really good mechanism also to eliminate potassium, and that mechanism in the body is renal, because you need tight control of potassium levels. Imbalances of potassium, even minor shifts in potassium, can cause significant issues within the body, especially things like cardiovascular dysrhythmias because of potassium's role in creating action potentials. Okay. So again, plasma potassium is regulated through two major mechanisms. One is those renal mechanisms that help to either conserve or eliminate potassium based on the amounts in the body. And we also have a mechanism where we can shift potassium transcellularly, so between the ICF and the ECF compartments, if we need to regulate that potassium balance. So let's dig a little deeper into some of these mechanisms of potassium regulation, both renal and these transcellular shifts. So we'll start with renal regulation. So this is really controlled via secretion from the blood into the tubular filtrate, out directly into the kidneys. For most electrolytes, when we talk about renal regulation, they're controlled by this kind of reabsorption, where things like electrolytes get filtered out initially and then reabsorbed at other portions in the kidney. It's a little different for potassium. These go directly into the filtrate and out rather than being reabsorbed. Again, needing that kind of much higher regulation is really why electrolytes, potassium kind of kidney regulation looks a little different. And aldosterone also plays an essential role through its role of sodium and potassium exchange. So again, in the presence of aldosterone, sodium is transported back into the blood, so it's retained, and potassium is secreted in the tubular filtrate um, for elimination into the urine. So that's the role of aldosterone, okay? And also at the level of the kidney, there's this exchange of potassium and hydrogen ions. Um, so when plasma potassium levels are high or increased, potassium is secreted into the urine and H plus is reabsorbed into the blood. So that exchange helps to, again, control or regulate potassium, but it also ends up producing an overall decrease in pH as we hold in more hydrogen. And this causes potentially metabolic acidosis. So if we have a patient with high potassium levels who needs to excrete a lot of potassium, we may end up seeing metabolic acidosis in that patient as we hold on to more H plus in that potassium exchange. Conversely to that, when potassium levels are really low and we're kind of reabsorbing or holding on to potassium, we might excrete more hydrogen, and that can lead to a metabolic alkalosis. And we'll talk more about the role of hydrogen in our acid-base discussion later on. Okay. At the transcellular level, again, this is a shift between the ICF and the ECF of potassium. So ion channels and sodium potassium pumps can temporarily shift potassium into the cells during times where we have excessive extracellular potassium. So serum osmolality, acid-base disorders, insulin and beta-adrenergic stimulation can all relate to these or be related to these shifts. So if we kind of look at this little diagram here, this kind of talks about that. So we have intracellular space inside the cell, and we also have our extracellular space. And so now if we're in a condition where we have too much potassium in this extracellular space, things like epinephrine, a beta-adrenergic stimulant, can help to push more potassium into the cell. Something like insulin can be given because that also acts as a conduit to transfer potassium from that extracellular to the intracellular space. We can also see that sodium potassium pump contribute to moving some potassium across. And we can also see some of these channels open that will allow this sort of exchange here at the cellular level of potassium and hydrogen ions as well, where we exchange a potassium ion, it moves into the cell, and we move a hydrogen ion out. I will mention too, just like it does at the kidney when we have this exchange, this also contributes to an elevation in hydrogen in that extracellular space, which can further lower the pH and vice versa. So there is a significant link between potassium levels and acid-base levels that, again, we'll talk about more when we get to acid-base. Exercise can also be a big releaser of potassium into the ECF, especially if there's kind of a lot of muscle exertion that can cause this big outward shift of potassium. Okay. So really acute increases in serum osmolality can cause water, as you know, to kind of leave the cell as it follows that fluid. And the loss of that cellular water produces an increase in intracellular potassium. And so that sometimes pushes potassium out of the cell into the ECF as well. Okay, so that's another kind of shift that we see with serum osmolality. So now that we've talked about some of the mechanisms to control um, potassium balance, let's talk about disorders that occur if that balance is not maintained. So we have hypokalemia and hyperkalemia. Hypokalemia refers to a decrease in plasma potassium levels where they drop below 3.5 milliequivalents per liter. This can happen due to an inadequate intake of potassium. Remember, we mentioned that we need to maintain dietary intake because we don't store. It can also happen if we're losing an excessive amount of potassium through the GI tract or through the renal excretion system, or maybe even through the skin. It can also happen if there's a significant redistribution between the ICF and the ECF compartments, meaning we've moved a significant amount of potassium, maybe from the extracellular into the intracellular compartment. So this might happen maybe in a patient with maybe a significant shift because of acid-base issues, where again we're moving potassium into the cell, leaving behind a hypokalemic vasculature. Hyperkalemia refers to an increase in plasma levels in excess of 5 milliequivalents per liter. The most common cause of this is decreased renal elimination. So we see this really commonly in patients who, have, renal failure. It can also happen if we administer potassium too quickly. We always give potassium, especially IV potassium, really slowly. And it can happen if we have a significant amount of movement of potassium from the intracellular space to the extracellular compartment. So in things like excessive exercise, we also see this maybe in patients with like extreme burns or trauma, where we have a whole bunch of tissue damage that releases all that potassium into that space. So again, kidneys really lack a mechanism to retain potassium during times of deficit. So like in the case of many other electrolytes, or non-electrolytes, the kidneys can really reabsorb them if we have low levels. But because of the different way that kidneys excrete potassium, we don't have as good of a mechanism to pull potassium back in as needed. So patients can get out of that potassium realm relatively easily compared to some of our other electrolyte imbalances. Also, redistribution of potassium can really be driven by things like insulin administration, where it would push potassium into the cell, or that kind of H plus K plus swap in acidotic or alkalotic states, or again, things like massive cellular trauma that releases a lot of potassium. So we'll talk a little bit about the clinical manifestations here. And what I have here is that kind of resting membrane potential, or that action potential. Remembering that potassium plays a really significant role in the depolarization and repolarization of cells that transmit electrical activity. So many of the clinical manifestations that we see are related to nerve and muscle function because of that critical role potassium plays in electrical conduction. And alterations in potassium levels significantly affect the rates of depolarization we see at the level of the cell. So that's what this really shows. In the black here is a normal threshold potential. In hypokalemia, which is in red, we get a much kind of lower, more negative resting membrane potential. So if you think about this as being the threshold at the dotted line, it will take longer for a cell in a hypokalemic patient to reach that threshold. So a longer period of time before we can get that action potential going. In a hyperkalemic patient, we have an overall increase of kind of that resting membrane potential. It's much closer to positive. So it's much easier to kind of stimulate or to get that cell closer to that threshold potential because we start at a much kind of less negative point in increased potassium. So this is kind of an important thing to maybe understand, to understand what's happening at that kind of electrical level. So the rate of repolarization really varies with plasma potassium levels. It's more rapid in hyperkalemia and delayed in hypokalemia. Okay. So we'll start with some clinical manifestations related to hypokalemia. And so this really shows, we haven't talked too much about EKG, but the hypokalemic EKG is kind of right here in the middle. This is normal up on the top. So there are some distinct changes that we see in an EKG of a patient who has low levels of potassium. So one thing we see is this really long PR interval. That's the time between when the atria and the ventricles contract. So that's much elongated. So remember, everything is kind of slowed down in hypokalemia. Again, we have that kind of much bigger distance between resting membrane potential and threshold potential. So again, everything is kind of just slowed down, right? All this is kind of really like kind of looks longer and depressed, just taking a lot longer for that electrical activity to kind of pass through because of that disruption in membrane potential. Other things we see in hypokalemia, anorexia, nausea, and vomiting is relatively common. Your GI tract, your peristaltic activity slows down significantly because those smooth muscle cells rely on electrical movement. Smooth muscle atony, or that slowing down of peristalsis, can lead to things like hypotension. In the cardiovascular system, we see these distinctive EKG changes, a lot of like prolonged repolarization. This can lead to bradycardia and eventually to ventricular arrhythmias. And patients also develop things like weakness, fatigue, muscle cramps, and even muscle paralysis if potassium levels drop really low. The treatment is to increase potassium, either via dietary means, which really is best, but maybe isn't fast enough in patients with severe, severe hypokalemia. We could also do oral supplementation or even intravenous supplementation. But again, when you're thinking about intravenous supplementation, that needs to be really done as slow IV infusion, because a rapid infusion of potassium can lead to cardiovascular dysrhythmia and can cause mortality. Okay, so now we're going to talk about the clinical manifestations of hyperkalemia. So a little cartoon here kind of shows some of those. Often what patients start to develop first with hyperkalemia are these paresthesias, or these kind of numbness and tingling in the extremities. It's one of the early manifestations. They can also get things like muscle weakness and dyspnea, or shortness of breath. They get changes to their cardiac conduction. You'll see that on the previous slide. You can look at some of those kind of classic or typical signs of cardiac changes. Again, we have kind of a more rapid rate of repolarization, electrical cell that's closer to that threshold potential, so kind of more easily stimulated is sort of what we see in hyperkalemia. The hyperkalemia is probably our most deadly electrolyte imbalance, because it can lead to ventricular fibrillation, which is a lethal heart rhythm, and cardiac arrest. A possible cause of hyperkalemia is multiple RBC transfusions. So patients who are getting a lot of red blood cells transfused really rapidly can develop hyperkalemia, so something to watch for in those patients as well. Treatment really varies based on the degree and elevation of the potassium, as well as the symptoms our patient has developed. So if they have high potassium with a lot of cardiovascular symptoms, we're going to be much more aggressive in treatment. One thing that we can do to kind of transiently reduce the kind of cardiovascular impact of high potassium is to give calcium. So giving intravenous calcium can kind of temporarily restore those normal levels of cellular excitability. It can bring that kind of resting membrane potential back down to sort of normal, so those cells aren't like super hyper excitable. But that's really pretty transient. It really helps for a very short period of time, maybe like 15, 30 minutes or so is really all that's going to help. But if you have somebody who's really irritated cardiovascular system with a lot of dysrhythmia, it's something that can be done to temporarily support that. We can also give sodium bicarbonate infusions. We can give beta adrenergic agonists, because remember, those can help to things like epinephrines can help to push potassium into the cell. We can give insulin, because insulin can help push potassium into the cell. So we give patients large doses of IV insulin along with maybe D50, so they don't get hypoglycemic, but that can give us some temporary relief to remove some of that potassium. If it's a non-emergent or like kind of not quite a severe case of hyperkalemia, we can just increase overall fluid intake to try to kind of dilute the potassium. Or we can do things to try to increase the excretion, like maybe giving a diuretic like Lasix that would increase secretion or excretion at the level of the kidneys. If we're dealing with a patient with kidney failure where those things might not work, those patients might just need to be dialyzed in that case. So now we're going to move on to the regulation of calcium phosphate, and then we're going to talk about magnesium balance. So calcium phosphate and magnesium are the major divalent cations, or so the positively charged ions within the body. They are primarily ingested within the diet, absorbed from the intestine, and filtered in the kidney for removal. as opposed to potassium, their filtration is largely related to being kind of reabsorbed in the renal tubules rather than just straight entering that filtrate, but they are ultimately eliminated in the urine. So we'll start with a little bit about calcium and phosphorus balance, remembering too the interplay of vitamin D here. So vitamin D is really acts as a hormone in this case, and it acts to sustain these normal plasma levels of calcium and phosphate because it helps to increase the absorption of those two cations at the level of the intestine. Parathyroid hormone is also a significant player in the maintenance of calcium concentrations in the extracellular fluid. And there's also a substance called calcitonin, which acts directly on the kidneys and the bones to help us remove calcium from the circulation if necessary. And then the other significant thing to remember about both calcium and phosphorus is that unlike something like a potassium, calcium and phosphorus are highly stored. We store a lot of them directly in bone. So if we need more calcium in the system, we can do that by action of the parathyroid hormones. And if we need more calcium to be stored, we can also, do that. So that storage mechanism is largely integrated into the mechanisms that kind of control those levels within the body. There are also several different types specifically of calcium within the body. Calcium often binds to proteins. So about 40% of the extracellular calcium is actually bound to albumin. There's also what we call complex calcium, where it's chelated or connected to things like citrates or phosphates or sulfates. And then the remaining 50% of calcium is what we call ionized calcium. So that's the calcium available in the ECF as kind of like a free form. And ionized calcium is the calcium that we can actually use in the body for the different processes, like the electrical processes that rely on calcium. So when we do serum markers, sometimes we measure what we call total calcium, which takes all three of these types into account. And normal levels are about 8.5 to 10. Or we can also directly test just the ionized calcium, and normal values for that, so this 50% here, are about 4.5 to 5.6. We often use ionized calcium levels specifically maybe in critical care settings where calcium imbalances are more common, and we need tighter control of calcium to maintain things like proper cardiovascular and muscle functioning. As we mentioned, parathyroid hormone has a significant impact on overall calcium balance within the body. So if we have patients with either hypo or hyperparathyroidism, we're also going to impact the patient's overall calcium balance. So hypoparathyroidism causes an overall deficiency in parathyroid hormone secretion, and these patients will have a resultant decrease in their plasma calcium levels. So patients without PTH will not be able to stimulate the release of potassium from those, or excuse me, calcium from the bone stores into the ECF to increase calcium levels. So no PTH equals low circulating plasma calcium. In patients with hyperparathyroidism, they are excreting an excess amount of PTH. So this results in an increase in plasma calcium. So that PTH excretion is signaling the bones to break down and release calcium into the system. Okay, so high PTH levels, high calcium levels. So usually the treatment of hypo or hyperparathyroidism first starts with trying to resolve calcium imbalances, doing what we need to do to try to maintain some of that calcium balance, and then looking for underlying causes of hypo or hyperparathyroidism and trying to solve those. If it's hypo-PTH from maybe a parathyroid deficiency, we can give PTH, but really a lot of the treatment is really just dealing with the calcium imbalance and the clinical manifestations that come with that. So we're going to start with hypocalcemia, some causes and symptoms. So one big cause of hypocalcemia is really this impairment of our ability to mobilize calcium from the bone stores. So hypoparathyroidism is a significant cause of this. That overall deficiency of PTH secretion will result in hypocalcemia. It can also happen from abnormal losses of calcium from the kidney. So if the calcium, maybe if diuretics or things might cause that. It can also happen if there's increased protein binding or chelation of calcium, remembering that only the non-ionized form is available. So if we have more calcium that is normally ionized, that starts to either chelate or combine with things like protein or other items, and we lower that percentage of ionized calcium, that can lead to hypocalcemia. And also if we get maybe soft tissue sequestration, so a overall movement of calcium into the tissues rather than in the circulation. Okay. Signs and symptoms of hypocalcemia are largely related to this overall increase in neuromuscular excitability. So the neuromuscular system becomes, again, hyper excitable. And then a lot of the other symptoms are cardiovascular in nature. So cardiovascular effects of acute hypocalcemia are things like hypotension, cardiac insufficiency or low cardiac output, and cardiac dysrhythmias, so abnormal heart rhythms. There are two significant assessments that we do for patients with hypocalcemia, and they are called Vostick's or Trousseau's sign. And we'll talk about those more in class and make sure you review those in your reading. But essentially what we're looking for, these are tests of that increased neuromuscular excitability. So for instance, something like Vostick's sign, we actually just take our finger and we kind of tap on the side of a patient's face. And that can cause a kind of muscle and facial contraction and twitching, again, because that neuromuscular excitability is so increased that even that small amount of stimulation causes muscle contraction. So treatment is either IV or oral supplementation if necessary, giving more calcium. If it is a lack of PTH that's causing this, we can give PTH by injection. If it's a lack of maybe absorption of calcium overall, we can increase vitamin D levels to try to absorb more calcium from the gastrointestinal tract. We'll move on to hypercalcemia. So what causes hypercalcemia? Well, it might be an increased intestinal absorption. Maybe someone who has taken excessive amounts of vitamin D and calcium supplements could get hypercalcemia. There's also something called milk alkali syndrome. That's excessive ingestion of calcium from milk alkali solutions. So things like milk of or different like preparations that might help with like constipation and things might contain large levels of calcium. We can also see this happen if we have what we call increased bone resorption. So again, patients who have excessive amounts of PTH or parathyroid hormone, where we get a lot of bone breakdown and subsequent movement of that calcium into the vasculature. Malignant neoplasms, if someone has a tumor that's growing within the bone that breaks down the bone and releases calcium. And also patients experiencing prolonged immobilization. So someone who is non-weight bearing for a prolonged period of time also experiences significant bone breakdown, and that calcium from that bone breakdown enters the serum and causes hypercalcemia. And we also can get hypercalcemia from decreased elimination. So thiazide diuretics will decrease the amount of calcium we're secreting in the kidneys, and lithium therapy can also affect our ability to excrete calcium. So signs and symptoms, changes in neural excitability. Neural excitability is decreased in people with hypercalcemia. So there's kind of this overall dulling of consciousness. They may become stuporous. Their muscles become weak and sort of flaccid. They also have a decrease in smooth muscle activity. So things like peristalsis might slow down. So they might have more like anorexia, nausea, vomiting kind of symptoms. We might see alterations in cardiac muscle function as well, so changes in contractility of the heart, and they may develop things like ventricular dysrhythmias or ventricular arrhythmias may develop as well. Treatment is rehydration, so we can give fluids to try to dilute or reduce those levels of calcemia in the blood. And then we may try to give things like diuretics that would help maybe excrete more calcium into the system. And then we would look for, again, underlying causes and try to treat them. If it's something like prolonged immobilization, if we can get someone up and moving, we would do that. If it's because they're taking too much calcium and vitamin D, we would, decrease that. We would, again, find that underlying cause. And we'll move on to phosphate. There's a very close relationship between phosphates in the body and calcium in the body. So phosphate role, things like phosphate plays a major role in bone formation. We need phosphates just like we need calcium to mineralize bones. Phosphate's also essential to a lot of the metabolic processes within the body. It's essential to the formation of things like ATP and a lot of the enzymes that we need to metabolize glucose, fat, and proteins are phosphate based. It's also a necessary component of a lot of the vital parts of the cells. So a lot of the things that make up the cells contain phosphates. And we also have phosphates that are incorporated into DNA and RNA, and it also makes up that phospholipid bilayer of the cell membrane. So very important to cellular structure and function. Phosphate also serves as an acid-base buffer, so it is in the extracellular fluid to help buffer or kind of eliminate a lot of hydrogen. So if someone has high hydrogen levels, phosphate can help to kind of buffer that and put pH back into a normal range. Phosphate is necessary for delivery of oxygen by the red blood cells, so oxygen delivery is reliant on phosphate. And it's also needed for normal function of other cells. So things like white blood cells and platelets rely on phosphate for their normal function. So phosphate's very critical to a lot of overall cellular functioning. So patients can become hypophosphatemic or hyperphosphatemic. Normal phosphate levels 2.5 to 4.5. Um, Hypophosphatemia is depletion of phosphate levels below that number, below 2.5. This can happen because of deficient or insufficient intestinal absorption. We bring phosphate in through the food. So if someone has an absorption issue or they have a malabsorptive condition, they might develop hypophosphatemia. It can happen because of transcompartmental shifts. If we're moving a lot of phosphate into the cell, we could get hypophosphatemia. And it can also happen in cases of excessive renal loss of phosphates. Okay. Hypophosphatemia results in altered neural function, disturbed musculoskeletal function. It can cause things like hematological disorders. Um, when we talk about intestinal absorption of phosphate, we can get intestinal absorption impairment if we have a patient who's taking a lot of calcium supplements, because calcium can bind to phosphorus in the GI tract. But this is also useful if we have a patient who has kidney dysfunction and they're not able to eliminate phosphate via the renal route. These patients often develop hyperphosphatemia. And so in those patients, we may give them calcium supplementation so that that calcium binds to phosphate within the GI tract and can lower overall phosphate levels in the blood. So that's a helpful thing too if we have a patient with renal impairment. Okay. Hypophosphatemia is also something we might see in patients who are alcoholics because alcoholism often leads to poor nutrition. So we see low levels of phosphates. Okay. Hyperphosphatemia often happens in patients. The most common reason are patients with kidney failure, and this makes them unable to excrete phosphate in the urine. Okay. We can also see it if there's a rapid redistribution of intracellular phosphate into the ECF compartment. So rapid redistribution might happen with things like massive like trauma or burns, things that break down a whole bunch of cells at once that release that phosphate into the system. And we can also see it in patients who have maybe an excessive intake of phosphorus. The other thing to know about hyperphosphatemia, as phosphate levels go up, that is associated with a resultant decrease in plasma calcium levels. So many of the signs and symptoms of phosphate excess are actually related to an overall calcium deficit. So hyperphosphatemia actually looks like hypocalcemia because they are hypocalcemic. So again, as phosphate goes up, calcium levels can drop. So that's another kind of important thing to remember. Then we're going to move on to magnesium balance. Magnesium is also an essential electrolyte in things like any reaction that requires ATP. So anything that requires energy, magnesium plays a role. The regulation of magnesium really happens at the level of the kidneys. Magnesium is reabsorbed in the ascending loop of Henle. I don't need you to really kind of know about that, but just know that magnesium is excreted in the kidney. So we need good functioning kidneys to be able to maintain overall magnesium balance. We bring in magnesium through the diet. So it's largely absorbed from the intestine and then it's excreted by the kidneys. So what does it look like when a patient has a relative decrease in their levels of magnesium? So hypomagnesemia. So this is a magnesium level below 1.8 milligrams per deciliter. That's the low level of normal for serum magnesium. So that's what you would see on labs. Okay. A lot of the manifestations we see with low magnesium are neuromuscular and cardiovascular related. There's also a kind of co-occurrence of hypokalemia and hypocalcemia in hypomag patients. They often all kind of happen together. So a lot of the time, the signs and symptoms that we see are sort of the co-mingling of those three things happening at one time. And I'll also say that you can't really treat low potassium if the mag is low. So you need to treat both. If you have hypokalemia and hypomagnesemia, you can give potassium all day, but you're not going to really achieve any maintenance of potassium balance unless you also treat the mag. Okay. So some of the neuromuscular manifestations that we see are things like maybe personality changes, what athetoid or chloroform movements, which are kind of these sort of like herky-jerky or uncoordinated movements that we see at various levels of the body. You can see nystagmus, which are these abnormal movements of the eyes, tetany, which is kind of like a kind of overall muscle like kind of tightening or hyperexcitability. We can see a positive Babinski, which is an abnormal reflex of the foot. And hypomagnesemia can also cause positive Vostick's and Trousseau signs that we also used, as you recall, to test calcium levels. We see things like tachycardia, hypertension, and cardiac dysrhythmias and hypomagnesemia. Adequate levels of magnesium are essential to maintaining normal blood pressure. If we have low levels, we get hypertensive. They're also essential for maintaining things like neuromuscular excitability. With hypermagnesemia, usually the reason that someone might get hypermagnesemia is probably because maybe of like an excessive intake. It's pretty hard if you have normal functioning kidneys to to give yourself too much mag. But sometimes we do that for treating other things. One of the treatments for a condition called preeclampsia that we see in pregnant women, preeclamptic patients are at high risk of seizure. So we often give MAG in those cases to lower the seizure threshold. And so those patients, if we're administering high doses of magnesium intravenously, are at risk of developing hypermagnesemia. Other patients are patients who use excessive amounts of oral magnesium-containing medications. Milk of magnesia is a common one here that patients often use for things like maybe constipation. If they use it in excess, they can develop hypermagnesemia. But again, pretty hard to develop this from like dietary or other sources because of the renal excretion. However, if we have a patient with kidney disease, maybe an acute renal failure or chronic renal failure, they lose that ability to excrete magnesium. And so decreased excretion is a much more common cause of hypermagnesemia. So hypermagnesemia actually diminishes neuromuscular function. So what we see in these patients is hyporeflexia, muscle weakness, and confusion. They get kind of really like loose, like flaccid muscles instead of that hyperexcitability that we see in high magnesium. They can also get things like low blood pressure. They might be fatigued, stuporous. Those are some things that we might see with high levels of MAG. This is another good spot to maybe take a break if you need one, because now we're going to move on to a discussion of acid-base balance. Okay. So we're going to start with some of the acid-base chemistry. So acids are things that release an H plus ion, and bases are things that accept an H plus ion. So acids are constantly being produced in the body through different metabolic processes. Metabolism produces CO2, which gets transported throughout the body. That's an acid. And really the ratio of bicarbonate, HCO3, and CO2 levels really determine kind of the overall pH in the body. Normal pH is 7.35 to 7.45, and the body does not tolerate well much shift outside of normal of that pH, especially if those shifts out of normal are acute or happen really rapidly. pH is really used to express the overall concentration of H+. As concentrations of H+ or hydrogen increase, your pH drops and you will become more acidic. As levels of H+ drop in the body, your pH goes up and you become more basic. There is an overall discussion in your reading on ways to calculate pH. I do not need you to know how to calculate pH. Because we need pH to stay in that kind of really tightly controlled range, there are a lot of different mechanisms in the body that help us to regulate pH. The first line of defense is what we call the chemical buffer system. There are chemical buffers in the intracellular and extracellular fluids. They help to be kind of the most immediate buffer, but they can be overwhelmed really quickly if there are really large changes in pH. So again, they're our first line of defense, but they don't have a lot of capacity to do a lot of buffering if there's a really big shift, okay? So these are things like sulfates, phosphates, and chlorides that are intracellular that can buffer things like H+ or CO2. That's what we see inside the cells. We also see extracellular fluid buffers like bicarbonate that kind of floats around in the extracellular space that can bind H+ ions to help kind of immediately buffer in the ECF. We also have respiratory control of pH. So that's kind of our next line of defense. You can see that kind of here in the white. So the respiratory response, as a patient becomes more kind of acidotic or their pH drops, what you see is a response by the respiratory system to try to excrete more CO2, which is considered an acid. And so if a patient becomes acidotic, their pH drops below 7.35, their respiratory rate increases, the depth of respiration increases as we try to eliminate more CO2 from the body from the respiratory system. The final mechanism to regulate pH is through renal mechanisms, so the renal control mechanisms. These mechanisms take the longest to kind of kick in, but they are also our most effective mechanisms for regulation of pH, okay? So we can, if we have a patient who's acidotic, who has really high levels of H+, they will excrete more H+, and we will also see an increase in development of different buffers, so more bicarbonate production within the kidney to help buffer H+ a little bit more, okay? If we have a patient who is has a elevated pH, they're more alkalotic, we might see more excretion of bicarbonate at the level of the kidney and a drop in production of bicarbonate overall. So again, this is really our renal mechanisms are really the kind of most do the best job of buffering. They just take kind of a longer time to kick in. Okay. So with acid base, there will be some kind of laboratory values and normals that you're just going to kind of need to know to be able to interpret what's going on with someone's acid base balance. One of them is carbon dioxide levels, so what we call PCO2. Normal PCO2 within the body is 35 to 45 millimeters of mercury. So it's a gaseous pressure that we use. And we measure PCO2 typically within the arterial system. So we draw blood from the arterial system. The vast majority of the time when we do serum markers of anything in the body, we take it from venous blood. We do a venipuncture, we take the blood. In the case of blood gases, they are arterial blood gases. So we're drawing them from the arteries. The other level are bicarbonate levels. Normal bicarbonate in a blood gas, in an arterial blood gas, is 22 to 26 milliequivalents. Okay, so that's normal. So again, those are things, pH, normal pH levels, normal PCO2 levels, and normal bicarbonate levels are things you're going to have to know. Okay. We also have some laboratory tests called base excess or base deficits. These are measurement of bicarb excess or deficit, and these indicate non-respiratory changes in acid-base balance. So if someone has a base excess or extra or high levels of base or bicarbonate levels, this indicates a metabolic alkalosis. And if they have low levels of bicarbonate or a base deficit, this indicates a metabolic acidosis. Okay. There's also something called an anion gap. Anion gap is a laboratory test that we use to try to distinguish different causes of metabolic acidosis. So we'll talk about those causes a little bit more in a moment. I'm not going to have you do too much with anion gap at this point, but just know it's, again, a laboratory test that we can use to distinguish what potential causes of metabolic acidosis might be, because identifying the cause in these acid-based arrangements is essential to kind of fixing them, right? So let's discuss a couple different disorders of acid-base balance. So we can have either metabolic or respiratory type acid-base disorders. So metabolic disorders are alterations in bicarbonate levels, and respiratory disorders are alterations in CO2 levels. And within metabolic and respiratory, we can have either acidosis or alkalosis. So the four different types of acid-base disorders are metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Okay. And again, it depends on whether or not we have excess of CO2 or excess of bicarbonate and what the underlying pH is. And we'll go through some of that kind of in class and some examples to make that a little bit more clear. Okay. But acidosis and alkalosis typically involve some sort of primary or initiating event that causes that derangement. And then in response to that event, your body kicks in with what we call compensatory mechanisms to try to bring the pH back into normal range. In the compensatory or adaptive state that results from homeostatic mechanisms that attempt to correct it or prevent or change these things are usually the opposite of what caused it. So for example, if we develop a primary metabolic acidosis, because we've created too much acid within the body. So maybe in the case of too much ketones, like ketoacidosis that we see in DKA. The compensatory mechanism for that is usually related to ventilation. So if someone has a metabolic acidosis, they compensate by breathing faster, breathing deeper to remove CO2 from the system to compensate. Okay. If a patient has something like a respiratory alkalosis, in that case, they may develop, again, a respiratory alkalosis because they're breathing really quickly. Okay. So compensation requires the use of a mechanism that's different from the cause of the acid-base derangement. So the body can use renal mechanisms to compensate for respiratory-induced changes in pH, and it uses respiratory mechanisms to compensate for metabolically induced changes in acid-base issues. So we'll start with metabolic acidosis. This is the most common acid-base disorder. There are a lot of things that can cause metabolic acidosis. Remember that, as we mentioned initially, metabolic processes are constantly producing acids. And if there's a metabolic process that accelerates so much that it produces acid that goes beyond our ability to buffer it, we get a metabolic acidosis. So that's really why these are kind of the most common, because we're always metabolizing. Okay. And so these are the types of acid-base disorders that we would use an anion gap with to determine the cause. There's this acronym, it's called MUD piles. It can be used to kind of remember some of the common causes of high anion gap acidoses. And MUD piles stands for methanol, so methanol poisoning, uremia, so uremia is what we see in patients with renal failure. Diabetic ketoacidosis is a common cause of this. Formaldehyde poisoning, isoniazid poisoning, so that's an antibiotic. Increases in lactic acid also cause metabolic acidosis. That's something that we talked about a lot already in its relationship to anaerobic metabolism. And the E in mud piles is ethanol, over indulgence in ethanol. And the final one is salicylate, so excessive ingestion of aspirin can cause metabolic acidosis. Okay, the causes are summarized in your book in table 8-17. Non-anion gap acidosis is most commonly caused by loss of a large quantity of base. So that happens in patients who maybe have like profuse diarrhea, or patients who were given a whole bunch of base containing items. So those are the more common causes there. Okay. So again, etiology, either increased production of metabolic acids that overwhelms the buffering system, or ingestion of fixed acids like salicylic acid, or the inability of the kidneys to get rid of those acids and buffer at that level of the kidney that we're making all the time from normal metabolism. Can also be caused by excessive loss of bicarbs. If we lose a whole bunch of bicarb, we can't buffer, and excessive concentrations of chloride. The clinical manifestations of metabolic acidosis are things like weakness, fatigue, general malaise, and headache. They may also experience things like anorexia, nausea, vomiting, and abdominal pain. If uncorrected, it can cause decreased level of consciousness. If our pH falls to levels near things like 7.1 to 7.2, it will start to impair our ability to maintain cardiac contractility. Cardiac output can start to suffer significantly. The heart can start to become less responsive to things like epinephrine and norepinephrine stimulation. Arrhythmias can develop, including fatal ventricular arrhythmias. So really low pH is not tolerated very well at all. Low pH is a medical emergency and needs to be corrected rapidly to prevent all of those cardiovascular things that we see. Okay. So treatment of metabolic acidosis really focuses on correcting the condition that caused the disorder in the first place. And then we start trying to restore fluids and electrolytes that have been lost as well. Remember, there's a significant that exchange of H plus and potassium. So we need to watch potassium levels closely, give fluids to help maybe restore kind of buffering and dilute some of that H plus. We can also give supplemental bicarbonate. So we can give sodium bicarb intravenously to help buffer the H plus. If someone has severe drops in their pH and they've developed things like circulatory shock, cardiac arrest, we would need to support them, especially if that cardiac arrest or sepsis or shock is the primary cause of lactic acidosis. Okay. We need to support things like tissue perfusion, and again, treat the underlying causes. The next disorder is metabolic alkalosis. This is usually caused by a gain of base through oral or intravenous route. So these are patients with a high pH, a pH above 7.45, and high levels of bicarbonate in the system. So bicarbonate levels above 26. Okay. So again, one big cause is giving a lot of bicarbonate either through the oral route or through the intravenous route. It can also happen if someone loses a lot of acid through the stomach, so things like a lot of GI loss. It can also happen maintenance of the increased bicarbonate levels by contraction of ECF volume, hypokalemia, and hyperchloremia. So if we get kind of a massive administration of base, If we have someone vomiting or who having a lot of GI suctioning, that removes a lot of circulating hydrogen. Patients who have large volume loss, patients who are given a lot of loop or thiazide diuretics because we lose a lot of H plus at the level of the kidney. Those are things that can cause metabolic acidosis, or excuse me, alkalosis. Okay. So when someone develops metabolic alkalosis, it leads to a compensatory hypoventilation. So if we have someone whose pH is up, we want to retain CO2 to try to bring that pH level back to normal. So these patients' ventilation slows down, and that might cause them to develop things like hypoxemia and maybe even respiratory acidosis if it goes on for a significant period of time. You can even, if metabolic alkalosis gets really severe, we're talking pH over 7.55, it can lead to things like respiratory failure, cardiac dysrhythmia, seizure, and coma. The good news here is like metabolic alkalosis isn't, super common. And so those kind of things are pretty rare where we see those really extreme cases of fatal metabolic alkalosis. Next up, I think we'll talk about is respiratory acidosis. So respiratory acidosis occurs in conditions that impair alveolar ventilation or alveolar gas exchange. And this causes our patients to retain CO2. And so their serum levels of plasma PCO2 go up. We call this hypercapnia, and this decreases their pH. So a patient with respiratory acidosis is going to have a pH below 7.35. And they're going to have elevated levels of PCO2. So common causes of respiratory acidosis are respiratory depression. So maybe a patient who is heavily sedated or a patient who is experiencing maybe a narcotic overdose would be at risk of respiratory acidosis. Patients with severe lung disease or airway obstruction where they don't have gas exchange start to retain CO2. Any of those things will increase CO2 content. So if you think respiratory acidosis, think airway obstruction or airway issues, right? So again, a pH lower than 7.35 and a PCO2 above 45 is an indicator of respiratory acidosis. And it's often accompanied again by hypoxemia. So the manifestations of respiratory acidosis are often intermixed with those of O2 deficit. Because CO2 readily crosses the blood-brain barrier, we see a resultant change of the pH of brain fluids. So elevated CO2 produces this kind of overall vasodilation of cerebral blood vessels. So this causes clinical manifestations like headache and blurred vision, irritability, muscle twitching, and psychological disturbances. If our respiratory acidosis becomes severe and prolonged, it can cause an increase in cerebrospinal fluid pressures, papilledema, impaired level of consciousness, anywhere from lethargy to coma, as PCO2 levels rise to extreme. We usually try to treat respiratory acidosis by improving ventilation. The fastest way we can treat this is to ventilate a patient. If we have a patient who has respiratory acidosis because they're not breathing, we breathe for them and try to blow off a lot of that CO2. So that's kind of our first line of treatment. And the final condition is respiratory alkalosis, okay? So this is characterized by a primary decrease in circulating levels of PCO2. We also refer to this as hypocapnia. So these patients will have an elevated pH above 7.45, and they will have low levels of PCO2, okay? Hypocapnia elevates our pH, and it can also subsequently decrease our bicarbonate levels. So we might see an overall decrease in bicarbonate as well, okay? So it's usually caused by excessive ventilation. So this is a patient who maybe is having an anxiety or a panic attack, and they're breathing really, really fast, and they're blowing off all this PCO2, and it's causing this respiratory alkalosis. It can also happen in patients who are being mechanically ventilated if we have maybe ventilatory settings that are inappropriate and causing someone to breathe too fast. And it can also happen in respiratory rate increases that we see in patients with metabolic acidosis. So if someone has metabolic acidosis and their respiratory rate increases to try to compensate, they can develop a resultant respiratory alkalosis. Okay. So again, reminders, pH is above 7.45, PCO2 is below 35, and bicarbonate levels are often low as well, maybe below 22, but you'll also see that concomitant drop in PCO2. Manifestations of acute respiratory alkalosis are usually really sudden. The person usually experiences lightheadedness, dizziness, tingling, and numbness of the fingers and toes. They also experience things like sweating and palpitations. They may feel panicked or feel this kind of air hunger, and they're often dyspneic or short of breath as well. Vostick's and Trousseau signs are often positive, and they can also experience things like tetany and convulsions. So respiratory alkalosis, again, is typically a compensatory state. And so treatment of respiratory alkalosis usually focuses on, again, correcting the underlying cause. So we need someone to increase their amount of CO2. If it's something like an elevated respiratory rate from panic, we can literally have someone breathe into a bag so that they're breathing back in some of their CO2. Respiratory alkalosis can not necessarily our most common acid-base disturbance, but can happen again in states of hyperventilation.